Personality Disorders, Treatability and Stigma by Gemma Roberts. The American and European psychiatric diagnostic manuals refer to personality disorders as enduring patterns of behaviour that deviate markedly from the expectations of one's culture, with pervasive and inflexible deficits which are stable over time. Approximately 1 in 20 people in the UK have been diagnosed with a type of personality disorder. Previous claims have estimated this number to be higher, however these results were based on less rigorous research. There is a lot of controversy around the label of personality disorder. Many people with the diagnosis feel that it is stigmatising and affects the treatment that they receive. This may stem from the long-standing debate around whether personality disorders are treatable as mental illnesses or whether treatment would fail, as some would argue that a person's fundamental characteristics cannot be altered. In this video, I'm going to summarise the debate around the treatability of people who are diagnosed with a personality disorder. I will also discuss the legacy of this debate, namely the stigma that people with the diagnosis still face today. When the Mental Health Act was passed in 1983, it was widely accepted that personality disorders were untreatable and therefore not the concern of psychiatry. Comparisons made in the DSM stated that mental illnesses are usually temporary, whereas personality disorders are diagnosed on the basis of long-term function and are stable across the lifetime. Mental health professionals felt that dealing with personality disorders was an impediment to the real work of treating people with discrete mental illnesses. By the late 1990s, personality was beginning to be seen as potentially plastic and capable of responding to the appropriate and skilled application of psychiatric and psychological knowledge. The most prominent evidence-based therapies for personality disorders are dialectical behavioural therapy, mentalisation-based therapy, and transference-focused therapy. There are also many others that have been specifically developed for the treatment of personality disorders, such as schema-focused therapy and cognitive analytical therapy. Whilst these therapies all vary in approach, it is argued that any therapy with the following 5 elements will be successful. These are a structured, manual-directed approach. Service users are encouraged to assume control of themselves. Therapists help connections of feelings to events and actions. Therapists are active, responsive, and validating. Therapists discuss cases, including personal reactions, with others. Linehan, Oldman, and Silk claim that the best treatment you can provide is a consistent and caring professional relationship. Drug treatments are also used for personality disorders, but these only focus on specific aspects of the pathological effects, such as affective instability and cognitive perceptual disturbances. Bateman et al. State that evidence exists that some second-generation antipsychotics and mood stabilizers could slightly reduce borderline personality disorder symptoms over the short term. They also point out that there are numerous risks associated with medication use, whereas psychosocial interventions carry fewer risks. In most cases, pharmacotherapy is only advised as an adjunctive to psychological or psychosocial interventions. The legacy of the debate around treatability has arguably led to the diagnosis of personality disorder being demedicalised. This can lead to less empathy and more stigma, as the person no longer assumes a sick role and takes on a deviant role. In 1988, it was stated that individuals living under the label of personality disorder were frequently excluded from health services and were often explicitly disliked by practitioners. This disdain was exemplified in an influential paper entitled Personality Disorder: The Patient's Psychiatrist's Dislike. This research examined psychiatrists' attitudes towards personality disorder and noted that people with the diagnosis were described as manipulative, attention-seeking, and annoying. Unfortunately, little seems to have changed in the 30 years that have since passed. In 2018, the campaign continues to battle the stigma of personality disorder diagnosis. The Personality Disorder Consensus Group released a statement which was supported by organisations such as Mind, the British Association of Social Workers, and several others. The consensus statement aimed to highlight the issues that people given the diagnosis face. They argue that the diagnosis should be helpful, as it can be a gateway for people to access the care they need. However, it is also often used as a reason to reject individuals from services. They also give recommendations for what would be helpful from services, such as a consistent and understanding professional, choice of treatments including therapies, and connecting with other service users. These suggestions are not unreasonable, and I would argue that the very need for this statement to be written shows how little services have progressed, despite the literature repeatedly showing us their flaws. There are many other critiques of the diagnosis. It is argued that it distracts from the etiological importance for psychological distress of the experience of childhood sexual abuse, and it pathologises survivors. 75% of those diagnosed with borderline personality disorder are women. Feminist critiques argue that the diagnosis is used in response to women's distress, particularly those who self-harm and have experienced childhood sexual abuse. It has been suggested that a different label should be identified for the cluster of symptoms that personality disorder currently describes. Suggestions in the literature to replace borderline personality disorder include complex attachment disorder and complex post-traumatic stress disorder. These terms were suggested because it was estimated that around 70% of people diagnosed with BPD have experienced childhood sexual abuse. Research has consistently found that there are negative views towards those diagnosed with a type of personality disorder, and those receiving the diagnosis are also unhappy with the label. It is now widely accepted that the words we and others use inform our thinking and judgment. We are becoming increasingly more aware of the language we use in order to overcome outdated views around concepts such as race and gender. I believe that in order to change the discourse around personality disorders, we first need to change the label, as to say that the essence of who we are is disordered is the ultimate invalidation.